Hi, today's topic of discussion is regulation of respiration. Respiration is regulated by a complex integration of neural control mechanism and also the chemical control mechanism. These two control mechanisms are modified by certain respiratory reflexes. And the respiratory system is only one system which has a dual control mechanism. What is that? That it has automatic control and also it has a voluntarily control mechanism. As we are discussing, there are two types of control mechanism. First is the automatic control. What is that? When you are in quiet situation, you are breathing quietly, you are unaware of your own breathing, how much air you are taking and how much air you are exhaling. You are unaware of that, and that is mainly done by this automatic control mechanism which is responsible for that. But still there are another mechanism which control your respiration voluntarily. Suppose you have to run for a 4 kilometer or do a marathon race. So for that you have to control your breathing obviously, or you are going to sing. So whenever you are singing the sargam, whenever it is going up, and you have to control your breathing, you hold your breath, and whenever you are coming down you have to hold your breath also. So what is that? That voluntarily control is completely different from the automatic control. So because it is a voluntarily, and because of the respiratory muscles or the skeletal muscle, they are supplied by the somatic motor neuron, and obviously the main center for this control is the neocortex, the cerebral cortex, but this bypasses a medullary respiratory centers. This medullary respiratory center is the main centers for the automatic control of respiration. Now, after this, from the neocortex, the project directly to the spinal respiratory neurons. This spinal respiratory neurons, directly on the spinal respiratory neurons, which ultimately supply the respiratory skeletal muscles. That means the phrenic nerve is a motor neuron which is arising from the spinal cord and C3 to C5, and it is a skeletal muscle. So this phrenic nerve or can control the respiration voluntarily also. The example of voluntary control of breathing is talking, singing, swimming, or breath holding. As we are discussing, there are two types of control mechanism. One is the automatic one. Now, what is automatic and how it is controlled? This is there's a nickname disease is there called online curse, which causes the patient suffers to die when they fall asleep. Okay, so there is a very funny story behind this. It's a mythological story. The heartbroken water nymph curses his husband, and she takes his automatic control of breathing. That means the person, when he is going to fall asleep, the patient is going to die. Only he can control his breathing voluntarily. The nickname disease is also called the congenital central hypoventilation syndrome. So whenever the person is falling asleep, the patient suffers to die. Before we are going to start the main discussion, we are going to know the overview of control of respiration. We are going to know new terms. And from this diagram, we can see there are two things. One is a central neural control, and another one is a sensory inputs, from where the sensory inputs are coming and who are giving the sensory inputs. Okay, first the central neural control. There's a pons and the medulla. In the pons and the medulla and the cortex, there are different area which can sense the different changes in the carbon dioxide partial pressure, oxygen partial pressure, and the H plus ion of the blood. Not even that, they can sense different changes in the muscle length and the position of the joint also. Whenever the lungs are getting stretched, the chest wall are getting stretched, this can be sensed by this brain centers. So what are the brain centers? First is the cortex, the pneumotaxic center, the apneastic center. There's a pontine group of central neural control mechanism, and there's a dorsal and the ventral medullary group of respiratory centers. Ultimately, from where they are getting inputs, the mechanoreceptors. Mechanoreceptors are giving the sensation from the stretch of the chest wall or the respiratory tract. Metaboreceptor, those are the getting the sensation when the muscle is exercising. Okay, and they're the peripheral chemoreceptor. As I told that they can sense. The chemoreceptor means obviously they can sense the chemical changes in your body, and what are the chemicals it get changed during respiration is the partial pressure of the oxygen and carbon dioxide and pH of the blood. Okay, and the respiratory muscles also coming into action. You will know there are inspiratory muscles. Main inspiratory muscles are the diaphragm, and other inspiratory muscles are the external intercostals, whereas the expiration is in quiet expiration is nothing, is a passive process. When the expiration is forceful, the abdominal muscles are coming into action to expel the air outside the body. Now, gross idea of ventilation. There's a schematic diagram where we can discuss about the higher centers, the medullary centers, and the nerves which are responsible to control the breathing. Now here, the higher center, as we know, this gives the neocortex, which gives the signal to the brainstem. And in the brainstem, what are the centers which are responsible? First one is a central pattern generator. This is the central pattern generator. This gives these are consisted of the pacemaker cells. Okay, and then next is the spinal cord. Okay, and next is the central chemoreceptors. These are the central chemoreceptors, and these are the sensory integration areas. So these are mainly the areas of the medulla of the brainstem. And there are peripheral chemoreceptor which are not present in the brain. It is away from the brain and the peripheral part of the body. And there are respiratory muscles which comes into action when there is inspiration and forceful expiration. And important chemicals, those are this partial pressure of carbon dioxide, oxygen, and pH. And what are the nerves are very important to know that these are the nerves which are carrying the sensation and giving the impulses to the central part, or mainly the medullary part of the respiratory center. Now you are going to get an proper idea of neurons which are responsible for your regulation of respiration. So respiratory neurons are in brain where they are situated. First, we have to know the name of the dorsal respiratory group. These are for inspiration. Another one is the ventral respiratory group, which are responsible for both expiration and inspiration. This is actually a brainstem cut out of the brainstem. The cerebellum has been taken off. This is the pons, this is the medulla, and the continuation down is spinal cord. And the sensation from the periphery is carried to this dorsal respiratory group of neuron, which is inspiratory mainly by the vagus and glossopharyngeal. Now come to other respiratory centers which is present at the upper part of the pons. This is called pneumotaxic center. And lower part of the pons, which is just above the medulla, is called apneastic centers. Now detail of that. Come to this diagram. Before that, the blue one is the inspiratory neurons. Red is expiratory neurons, and the inspiratory expiratory both are yellow. So this part is pons, this part is medulla oblongata, and this part is spinal cord. First comes to the inspiratory group of neuron. As we know, this is a dorsal respiratory group. So where it is situated, this is the medulla oblongata, and both the side of the midline dorsal respiratory groups are present, groups of neuron are present around the nucleus tractus solitarius. These are also nucleus. Nucleus means the cell bodies of so many neurons. Okay. And what is the ventral respiratory group consisted of? These, as we know, those are consisted both the expiratory neurons and the inspiratory neurons. So these are the ventral respiratory group. The caudal part of this ventral respiratory group is called Botzinger complex, and the lower part, the rostral part, is called the nucleus. This is retroambiguous and ambiguous. These two, the red, are the expiratory neuron of the ventral respiratory group, whereas the blue one, the middle one, is the inspiratory neurons. These inspiratory neurons are the nucleus retroambiguous. Clear? And the upper part of the pons, the pneumotaxic center is consisted of nucleus parabrachialis and nucleus collicular fuse. You have to remember that. And the lower part of the pons, just above the medulla, this is the apneastic center. Now we are going to know the details of these respiratory neurons. First, dorsal respiratory group of neurons, or DRG. Coming to this diagram, this the position of the dorsal respiratory group. This is mainly the inspiratory neurons. So dorsal is a dorsal location in the medulla, okay, and is behind the medulla actually. It is located bilaterally around the nucleus tractus solitarius. The DRG primarily contains the neurons for inspiration, and this NTS, this nucleus tractus solitarius, receive the sensory inputs from the receptor, mainly the stretch receptor, which is present around the thoracic and abdominal viscera. The DRG mainly responsible for the inspiration and also the integration of the sensory information that is originating from respiratory system. These neurons which are arising from the DRG directly project to the cell bodies of the phrenic nerve, which is present in the again medulla and spinal cord C3, C5 level, and these motor neurons in ultimately supplying the diaphragm, the main muscle of inspiration. Now we are going to know about the ventral respiratory group of neuron and the central pattern generator. We have discussed about this diagram, whereas this is the inspiratory neuron, expiratory neuron. Ventral respiratory group of neuron contains both inspiratory and expiratory neurons though. Where they are situated, they are mainly situated in the nucleus ambiguous and the retrofacialis of the medulla oblongata. This contains inspiratory and expiratory neurons. Cells are the nucleus are present mainly expiratory are the retrofacialis. This nucleus of the nucleus ambiguous, which is responsible for the inspiration, and rostral expiratory group, which is called the Botzinger complex, which are expiratory, and the caudal one, which is responsible for the expiratory group. The middle one is responsible for inspiratory group. This middle one is for inspiratory, whereas the rostral one is called the Botzinger complex, which is responsible for expiration. Now another called the central pattern generator. This is pre-Botzinger complex. This is actually present around this Botzinger complex. These two are Botzinger. Around this Botzinger, another complex of pacemaker cells are present over here. These are called the pre-Botzinger complex between the nucleus ambiguous and lateral reticular nucleus. These neurons, these pacemaker cells in the pre-Botzinger nucleus complex is discharged rhythmically to activate the phrenic motor neuron in the spinal cord, which produces the ramp signals or ramp generator, and this is called the central pattern generator. Now, what are the motor outputs of this dorsal and the ventral group of respiratory neurons? This is first we are going to discuss about the inspiratory neurons. As we have seen in the last, this is the VRG, this is the DRG. First, we are coming from the DRG. There is an inspiratory group of neuron. You see here, when we are taking inspiration or the forceful inspiration, we have to open your mouth or phares and airs, and also pharynx and the larynx should be open. So the cell bodies of these areas neurons are situated in the DRG. So which opens the mouth with flares the nostrils, and it maintains the opening of the larynx and the pharynx and the other muscle also. So mostly they are the fifth Then this is the 7th, the facial muscles. There is the 9th, 10th, and 11th one. And what are these? These are the VRG. These are situated in this VRG. The middle part is again the inspiratory one. These are giving rise to the phrenic nerve. You see this phrenic nerve which is supplying the diaphragm. So these are initiating from the cell bodies of the phrenic nerve are situated in the C3, C5 and also here in the medulla in the middle part of the VRG. And also the spinal nerves with the inspiratory intercostal muscles, means external intercostal muscle, these are giving rise. So this phrenic nerve, actually they are arising from the C3, C5 of the spinal cord, but these are mainly getting information from the ventral respiratory group of neuron which is present between these two, Bodzinger and the lower one. So from there one neuron is arising, coming to the ending into the spinal cord C3, C5, C3 to C5. From there the phrenic nerve is arising and giving response to the diaphragm, which is the main muscle for the inspiration. Another one, it is arising from this DRG also, or the around this whatever it is there, pre-Bodzinger complex, it is giving the inspiratory muscles other than the diaphragm. Those are the external intercostals. Now coming to this expiratory group of muscles, we know the expiration passive is process when it is a quiet situation, but when expiration is a forceful, their muscles should contracted, and mainly the internal intercostals and the abdominal muscles. So from where they are getting the VRG, the Bodzinger complex and the lower part of the VRG, where from there the signals are coming, the cell bodies are arising from there, giving to the spinal segments of that, and from there the motor nerve is arising, spinal motor nerve is arising and supplying to the internal intercostals and the abdominal muscle, which are muscle for the expiration. Now, two other pontine centers we know. One is a pneumotaxic center, another one is a apneastic center. First, this is pneumotaxic center is situated upper part of the pons, as we have seen the diagram, and formed mainly the nucleus parabrachialis. What is the function of this pneumotaxic center? Mainly, it controls the medullary respiratory center. You just remember medullary respiratory centers are the DRG and the VRG. It is controlled by the pneumotaxic center. Mainly the inspiratory center, okay, not the expiration, because this is through the apneastic center. It always controls the activity of the inspiratory center. So the duration of the inspiration is controlled. Means the inspiration, whenever the person is going to take a deep inspiration, the pneumotaxic center starts firing. So after the tidal volume, after the effortful inspiration, this pneumotaxic center starts firing at it limits the overinflation of the lung. So it is very important to decrease the overinflation of the lung, which causes the bursting of the alveoli. Now, what is apneastic center? It is situated in the lower part of the pons. The function, the centers increases the depth of the inspiration by directly acting on the inspiratory centers. Continuation of the last slide, the pons respiratory groups. First is a apneastic center, and it mainly stimulates the inspiratory center, and it causes a strong inspiration or it's a prolonged inspiration, which is completely different to the pneumotaxic center, which inhibits the VRG to end the respiration. I told the overinflation it's mainly controlled by the pneumotaxic center. It provides a smooth transition between inspiration and expiration. It's the stimulation of this center inhibits the apneastic center, which mainly increases the inspiration. So to switch off this, the pneumotaxic center is mainly responsible. It contributes in expiration. It stops the inspiration and starts the expiration. Mainly it provides a smooth transition between inspiration and expiration. Other centers, the cortical center, the neocortex we are talking, we can actively affect our respiratory rate, such as the holding the breath under the water, as I told, the voluntary control of the respiration. And the limbic system of our brain and hypothalamus also stimulates the respiratory system. When the emotional effect of the respiration, when we are emotionally active, then respiratory rate may increase. And now, integration of the neural mechanism. First, the inspiration. The inspiratory neurons exhibit a constant discharge throughout the inspiration. If sometimes stops means the inspiration will stop and the patient will die. So there should be a constant inspiratory neuron outburst. Otherwise, respiration cannot be continued. And then the ramp-like discharge during inspiration, the inspiratory ramp neurons, mainly the central pattern generators, are responsible for that. And also along with that, DRG is also responsible for that. The whatever the signals the patient, the human is getting from the different stress receptor present around your lung and the chest, and also the chemical sensors, whatever it is there, they are getting information from to the DRG, and this gives a ramp-like discharge always till the end of the life. The increase in the ramp activity ensure the smooth increase in the lung volume and inspiration. Okay, and the phrenic nerve activity becomes silent. That is very much important. Phrenic nerve, which is responsible for, which is supplying the diaphragm, which is main inspiratory muscle. The phrenic nerve activity becomes silent during expiration, except at the early part of its some burst activity. Means it is telling that the expiration, whenever the first part, the phrenic nerve still it is giving some signals, but the second phase, what is happening, we are going to know. Now comes to expiration. As soon as the inspiration is terminated, some inspiratory muscle activity still persists. That's the first phase of expiration we are telling. Then next is the second phase of expiration. The inspiratory muscle activity totally ceases. There is no muscle contraction and the expiration is totally passive process because of the lung recoil property of the lung recoil, and obviously during quiet breathing. But during the forceful expiration, there is a contraction of the expiratory muscle, which gets the information from the expiratory group of neuron we have discussed before already. The expiration depends on the degree of the inhibition of the inspiratory neuron in the DRG and the VRG complex. This point is very, very important. The expiration, when it will start, the expiration depends on the degree of the inhibition. The mainly degree of the inhibition, it comes the pneumothoracic center, okay, and which switch off the inspiration. Whenever the DRG gets switched off, the expiration starts. So it is very important. The expiration depends on the degree of the inhibition of the inspiratory neuron in the DRG and the VRG complex. So again, after inspiration, again the inspiration starts. So it is becoming a cycle. The inspiration, when it stops, and then expiration start. It is a passive process. Expiration switched off by the expiration is inhibited, depends on the degree of the inhibition of the inspiratory muscle, and then again inspiration starts. Now, other areas which is responsible for inspiration and expiration. Role of vagus. Vagus nerve carries the afferent fibers from the lung and airways. Very important, vagus nerve. And during inspiration, stretching of the lungs, I told before, there is a stretch receptors in the chest wall and the airways. Parenchyma increases the discharge of this afferent vagus. Afferent vagus means taking the sensation from this muscle towards CNS, or the central nervous system, that is a medulla oblongata, which is originating from the lung. So from lung, the stretch receptor, they're giving us signals. The vagus nerve is carrying that and taking the signals to the medullary respiratory centers. And afferent vagal impulses inhibits the medullary inspiratory neurons. This limits the depth of the inspiration. So overstretch is controlled by the vagus nerve, which is acting as the afferent nerve for that. Now, vagotomy prolongs the inspiration. If you do the vagotomy, the efferent sensation, it doesn't go from this stretch receptors to the medullary inspiratory area, and the inspiration will be prolonged. Now come to the center, higher center. What are the centers which are responsible for that? First is a reticular activating system. Reticular activating system, which is mainly responsible for our awakefulness. And how it helps in the respiration? RAS, or the reticular activating system, exerts a tonic drive on central pattern generator, which is increased during arousal of sleep. So I told you the reticular activating system is very much important for your awakefulness. So it gives it, whenever this is activated, the reticular activating system, when you are going to awake or during this gives the signal to the central pattern generator. So in that way, your inspiration will be controlled. Another one is the limbic system and the hypothalamus, which is mainly related with the emotions and the respiration. The many areas of the cerebral cortex control the medullary respiratory, other centers also. Now, the afferent impulses from the non-chemical receptors. First, the afferent impulses from the pulmonary stretch receptor. As we have discussed before, there are several pulmonary receptors. Those are the stretch receptor stimulated when there is stretched, more stretch, means overinflated. Mainly, this reflex is called the Herring-Brewer's inflation reflexes. There is a deflation also. So, this limits the overinflation of the lung and the chest wall. Afferent impulses from the J receptor, and other afferent impulses afferent are going from the irritant receptor, which are going to protect our lung from the different deleterious chemicals like the smoke and the dust, so many things. So what are those? The first are mainly there's a cough reflex, the sneezing reflex, the Herring-Brewer deflation reflex, and also the deglutition reflex. We are going to discuss later these all. Afferent impulses from the proprioceptors, mainly from the exercising muscle. Whenever we are going to start a race, we are taking a deep breath, or our due to this our respiratory rate increases. Because of this proprioceptor giving the impulses to the DRT, and the inspiratory rate is also increased. Afferent impulses from the stretch receptor, and afferent impulses from the baroreceptor, which maintains the blood pressure. Now, Herring-Brewer inflation reflex. Here is a cycle. It's actually a reflex, means it starts and ends. So it's a cycle. So inspiration, tidal volume is, normal tidal volume is 500 milliliter. If it is more than that, that is more than 1000 ml, then what is happening? There is an overstretching of the lung. This stimulation stretch receptor into the air passage, it goes to the impulses carried through the vagal efferent, and as we discussed before, vagal efferent inhibits the dorsal respiratory group, and the dorsal respiratory group is mainly responsible for the inspiration. When it is inhibited, the inspiration stops, so the inspiration is checked in and the tidal volume comes back to the normal level. So this is called the Herring-Brewer inflation reflex, because of the overinflation of the lung, this reflex happens. Now we are going to discuss about the J receptor and the C fiber, the pulmonary C fiber. This are located adjacent to the alveoli and are accessible to the pulmonary capillary circulation. So it is because of this adjacent, that's why it is called juxtacapillary, and the J name has come like this. J means juxtaposition to the pulmonary capillary, and this has been described by Indian scientist Dr. A.S. Paintal. And this type of fibers from the receptor, which from these whatever it is arising, these are a very thin and myelinated fiber, and these are called pulmonary C fiber. Stimulated by various lung injuries, marked inflation, severe inflation, acute pulmonary vascular congestion, the pulmonary edema, accumulation of the fluid in between the pulmonary capillary and the alveoli, the pulmonary edema, that is the vascular congestion, and the certain chemical agents. When it is stimulated, what does it do? That is rapid shallow breathing, then bronchoconstriction, increased airway secretion, and cardiovascular depression. So this is a lung J receptor. Actually, it is situated just between the alveoli and the pulmonary circulation. So when it is stimulated, there is an overinflation of the alveoli. It causes the stimulation of this, and or there is a pulmonary edema. Afferent impulses from the irritant receptor in the respiratory tract. First is a cough reflex. It is a protective reflex, and it causes stimulation of the irritant receptor in the pharynx, larynx, and trachea and the bronchi. You know, something is stuck in your pharynx or larynx, you started cough, and it should not go to the lung. So it is a protective reflex, and it comes out from the respiratory tract. Then the sneezing reflex, the protective reflex again, and these are also stimulation of the irritant receptor in the nasal mucosa. So whatever is bigger dust or the something is there in the nose or the nostrils, so it should not go inside to the lung, which causes deleterious effect, and it sneezed out. And then the Herring-Brewer deflation reflex, the stimulation of the retained receptor located in the bronchial epithelium. due to distortion of the bronchial epithelium caused by the large deflation, because before it was inflation. Large deflation means atelectasis. It gets pneumothorax, or maybe pneumothorax is giving the pressure on that, so it is called the hearing brewer deflation reflex. It comes back to normal actually. Deglutition reflex, the temporary apnea. Apnea means cessation of breathing during pharyngeal phase of the swallowing of the food. So the food, the esophagus and the trachea, which is situated side by side in the front and the behind, when the person is deglutating something, so the food should go always, due to gravity, should go always towards esophagus, not towards the trachea. In that, there is a temporary apnea. So what is happening? Apnea means there is a closing of the glottis and it flips down and close the passage of the trachea. So their food cannot go inside the trachea. Instead of that, it goes towards esophagus. This is called the deglutition reflex. These are the protective reflex. Now we are going to start about the chemical control of breathing. Before that, we were discussing about the neural control of breathing. As we discussed, there are the two types of control. One is a neural and another one is a chemical control of breathing. These are integrated together and bring about the whole respiratory regulation. Mainly this receptor, there are various receptors which sense the partial pressure of the oxygen, partial pressure of carbon dioxide and H+ ion of your blood. So the sensor, where they are present in the central chemoreceptors. Centrally means it is present in the brain, and another one is the peripheral chemoreceptors. And the inputs are integrated in mainly the medullary respiratory centers. So what are those areas and how it is integrated, we are going to know. Now we are going to start about the central chemical control. Then you have to know the chemoreceptors which are present in the medulla oblongata. There is a ventral surface of the medulla oblongata. What is the exact location? Central chemoreceptors are the cells, there is the neurons that lie beneath just the ventral surface of the medulla oblongata. Okay, and these neurons forming the central chemoreceptor project directly over the respiratory neurons. From here, these neurons actually, it's giving the impulses to the DRG and the VRG to control the respiratory rate. And what is the main stimulator of this is this chemical control is H+ ion of CSF. As we know, the carbon dioxide concentration affects the central chemoreceptor. Actually, there's a partial pressure of the carbon dioxide. Carbon dioxide readily crosses because it is very much soluble the blood-brain barrier, and after entering into the CSF in the presence of the carbonic anhydrase, it is this carbon dioxide and water forms this bicarbonic acid, and the carbonic acid then goes to bicarbonate and H+ ion. This H+ ion is the main stimulator for this central chemoreceptors, and after getting stimulated, this central chemoreceptor gives the impulses to the DRG and the VRG. This central chemoreceptor are not stimulated by the hypoxia. You have to remember that these are only stimulated by the H+ ion and ultimately mainly the partial pressure of the carbon dioxide. So whenever the partial pressure of the carbon dioxide is increasing, this central chemoreceptor are going to stimulate and giving the impulse to what? DRG and the VRG. If the impulse is going to the DRG, the respiratory rate increases and there is a washout of the carbon dioxide. So the partial pressure of the carbon dioxide decreases and it comes to normal. This central chemoreceptor are also inhibited by the anesthesia, cyanide, and during sleep. Now we are going to discuss about the anatomy of peripheral chemoreceptor, where they are situated. They are mainly situated in the aortic bodies and carotid bodies. And the carotid bodies are the bifurcation of the common carotid artery, and the aortic bodies are over the arch of the aorta. And how they act as peripheral chemoreceptor. The carotid bodies are very small, chemosensitive organ having the 2 millimeter width and weight of 2 milligram. And they are located at the bifurcation of the common carotid artery, and afferent nerves from here is going to this DRG or the dorsal respiratory group is glossopharyngeal. So these are the afferent nerve, and this receives the high blood flow because it is a very high blood flow. The highest amount of the blood flow, it happens per unit weight of the tissue. It is the highest in the carotid bodies, that is the about 2 liter per 100 gram of tissue per minute. That's why it is 40 times of blood flow to the brain. So because of this amount of the blood is flowing per minute, it can access a very little less of partial pressure of oxygen. Whenever there is a decrease in partial pressure of oxygen, very little amount, then only it is sensed by this peripheral chemoreceptor. Due to greater flow, the carotid body easily detect the minor changes in the not only the partial pressure of oxygen, partial pressure of carbon dioxide, and pH. Another one is aortic bodies, and these are located along the ascending aorta and the arch of the aorta. They are innervated by the vagal afferent. This is a sensation taken by the vagus nerve, whereas here the sensation is going through the glossopharyngeal nerve, and they also contain the glomerus cells similar to the carotid body, which are chemosensitive. Now coming to the glomerus cell. What is glomerus cell? The carotid body consisted of the two types of cells. One is type 1 glomerus cell and type 2 glomerus cells. Type 2 are actually the sustentacular cells. They surround the cluster of the glomerus cell, type 1 glomerus cells. And this type 1 glomerus cells is actually chemosensitive cell in the carotid bodies. These glomerus cells are spherical in shape. These are the spherical in shape and a diameter of 10 micrometer. And they are neuroectodermal in origin. And the specialty of this neuroectodermal cells, they have the voltage gated ion channels on their membrane and many granules. What these granules contains? These granules are norepinephrine, dopamine, and substance P. These, this chemical substance, especially the catecholamine, are releases when they are stimulated by hypoxia or the decreased partial pressure of oxygen. And the dopamine is released in the glomerus cell, acts on the D2 receptor of the ninth nerve. There is a glossopharyngeal nerve, D2 receptor. Dopamine is secreted from these glomerus cells, and D2 receptor is present on the glossopharyngeal nerve, and this sensation is taken up to the dorsal respiratory group of sinus neurons. Now the main response of the glomerus cell to the hypoxia. So hypoxia is a main stimulator, that is a decrease in partial pressure of oxygen, which is sensed by the chemosensitive cell, that is of the carotid bodies and the aortic bodies. Those are the glomerus cell type 1. Okay, and this glomerus cell, as we know, this is a voltage gated ion channels are present. The hypoxia mainly there is a loss of oxygen in the heme containing group, and also there is a mitochondrial NADPH oxidase. And is this hypoxia increases the cyclic AMP inside this glomerus cell. Okay, these all three causes inhibition of the potassium channel, because increase in cyclic AMP causes inhibition of the potassium channel. Because of the increase in potassium inhibition of the potassium channel, potassium cannot go out of the glomerus cell to the exterior or the extracellular fluid. So decreased potassium efflux causes depolarization of the glomerus cells because of the increased concentration of the potassium. This depolarization of the glomerus cell causes depolarization induced voltage gated calcium channels to be opened. And after opening, this influx of the calcium happens, and this calcium causes this calcium mediated release of the neurotransmitter that we have discussed, that is mainly dopamine, and increase in the rate of the discharge, and this dopamine are going to bind with the D2 receptor, which is present on the postsynaptic membrane, that is a ninth cranial nerve, and the stimulation of the respiratory center, the DRG, that centers this response is integrated in the DRG and the inspiratory area of VRG. So increase the ventilation. Ultimately, the partial pressure of the oxygen is neutralized. As of now, we have an idea of that increased partial pressure of the carbon dioxide, which increases the central chemoreceptor, and decreased partial pressure of oxygen, which stimulates the peripheral chemoreceptor. But when the PO2 is less than 60 millimeter of Ag, the hypoxic drive by this peripheral chemoreceptor are strong enough. Why? What is happening between 100 millimeter of Ag to 60 millimeter of Ag? Why it is taking time to become strong below 60 millimeter of Ag? That is very important to know. So decrease in partial pressure of oxygen less than 100 millimeter of Hg results in progressive increase in the firing state of this afferent nerve, that is the glossopharyngeal and vagus. Okay, and the response become prominent when it becomes 80 millimeter of Hg, and it is most effective below 60 millimeter of Hg. So what is happening between 100 to 60 millimeter of Ag? There are two things happening. Why this in between this partial pressure of oxygen 100 to 60, the respiratory hypoxic drive is not enough to increase the drive. What is the first is a braking effect of carbon dioxide. So as we know, the carbon dioxide is the most potent stimulator for the central chemoreceptor. The central chemoreceptor, when there is increase in carbon dioxide, so it gets stimulated by the H plus ion. There is an increase in ventilation and there is a washing out of the carbon dioxide. So and that leads to decrease in partial pressure of the carbon dioxide, which inhibits the respiration obviously through the DRG. This decrease in carbon dioxide because of the washing out, this signals goes to DRG, and ultimately there is a decrease in respiratory rate, and the central chemoreceptor balances that. So that is opposes and neutralizes the effect of PO2, decreased PO2, which is happening between 100 to 60 millimeter of Hg. Another thing, due to hypoxia, there is a very interesting thing. Amount of the deoxyhemoglobin is decreased. Hypoxia means partial pressure of the oxygen is decreased. Deoxyhemoglobin means there is a hemoglobin, whatever it is present, it is not saturated with the oxygen because of the partial pressure of the oxygen is less. As we know, the deoxyhemoglobin is a weaker acid compared to the oxyhemoglobin. Means when the hemoglobin is bound with the oxygen, this is a much stronger acid than the deoxyhemoglobin. So as a result, there is a decrease in H plus ion. As this H plus ion decreases, this nullifies the hypoxic drive of the ventilation. Because of the decrease in H plus concentration, this is not going to stimulate again the respiration. So it nullifies the hypoxic drive. So unless it is becoming below 60 millimeter of Hg, the response is not effective so much. As we have discussed, the glomerus cells are also stimulated by the increase in partial pressure of carbon dioxide, that is called hypercapnia. So what is happening when there is an increase in partial pressure of carbon dioxide? What is happening in glomerus cell to fire? Increase in partial pressure of carbon dioxide, entry of the carbon dioxide in glomerus cell. Increase in carbon dioxide causes dissociation with the water and produces H plus ion. And there are hydrogen sensitive potassium channels are there. When there is an increase in hydrogen, this potassium channels are going to inhibit. Ultimately what is happening, there is a efflux is closed and decreased, and there is a depolarization due to increase in potassium concentration inside the cell because of decreased efflux, and this causes depolarization of the cell. So voltage gated calcium channel, again it opens, the calcium influx happens, and calcium mediated transmitter neurotransmitter releases, and increase in night cranial nerve stimulation, and there is a stimulation of ventilation. Now integration of the chemical control of respiration, we can see here what is happening. uh, Three things, that is a partial pressure of oxygen, partial pressure of carbon dioxide, and hydrogen ion. Decreased partial pressure of oxygen is sensed by peripheral chemoreceptor as well as the hydrogen ion also, and the increased partial pressure of carbon dioxide is sensed by the central chemoreceptor, ultimately the increase in hydrogen ion, which dissociates the carbon dioxide from to carbonic acid, and then bicarbonate and hydrogen ion, which is going to stimulate the central chemoreceptor. Both central chemoreceptor and peripheral chemoreceptor give the signal to the medullary respiratory center to increase ventilation. Here we come to the end of this regulation of respiration. Now time to summarize. As we know, there is two types of control. One is automatic and another one is voluntary. Automatic is in the quiet breathing. We are unaware of this breathing, and there is a neural control and also the chemical control. First, the chemical control. There is the chemicals which are responsible for the control of this are carbon dioxide, partial pressure of oxygen, and pH, sensed by the peripheral chemoreceptor and central chemoreceptor. The nerves which are responsible is glossopharyngeal vagus, taking the sensation to the central chemoreceptor and from the peripheral chemoreceptor, giving the sensation to the medullary center to increase of ventilation. And what is a neural control? Neural control, they are situated in the upper part of the pons, that is a pneumotaxic center, and the lower part of the pons is a apneastic center, and in the medulla there is a DRG and VRG. DRG mainly the inspiratory neuron, whereas a VRG contains inspiratory and expiratory neurons. And these sensation from the brain stem, they mainly coming from the muscles and also chest wall stretch receptor, and also coming from the chemoreceptor. There is another thing is called central pattern generator. These are the pacemaker cells that are the pre-Porzinger complex, giving the sensation to the spinal cord. From there, the respiratory neurons, the motor neurons, mainly the phrenic nerve, and the neurons which are supplying to the external intercostal muscle are arising and supplying to the respiratory muscles. And this whole part, this side is automatic control, whereas the higher central directly coming to the spinal cord, giving rise to the signal from the spinal cord to phrenic nerve and external intercostals are voluntary control, bypassing the medullary center. Thank you.